My name is Jan Belohlavek. I'm a cardiologist, intensivist, and invasive cardiologist. I'm a professor of medicine, and in my clinical practice, I focus mainly on acute cardiology, cardiac arrest, post-CPR care, and refractory cardiac arrest and extracorporeal CPR. Research-wise, I'm also involved in animal research and lab research, again on extracorporeal CPR, microcirculation, and animal models of cardiogenic shock and cardiac arrest. It's been a long time ago. It was actually in 2006, and I remember exactly well what happened. It was one of the cases I had. We resuscitated a young woman who was 25 years old, and I resuscitated her for 2 hours, and she died under my hands. So, and in that case, that time I decided we have to do something more for those patients who have a so-called refractory cardiac arrest. Means that patients with cardiac arrest don't react or are not able to, we are not able to get the ROSC, return of spontaneous circulation. And it was an impulse to start with ECMO and using ECMO in cardiac arrest cases. So we started using ECMO routinely in 2007. We started putting patients on ECMO during cardiac arrest in 2010. Then we thought about the protocol of the study because we were not sure whether this worked. So it was necessary to undergo a randomized trial. So we designed randomized trial during 2010 and 2011. It took us quite a long time to get an approval from the ethics committee because the trial is very difficult actually. And then in 2012, we published our protocol, and in 2013, we started the randomized trial. It's a Prague OHCA, we call OCHA, out of hospital cardiac arrest study. Means that this study is focused on patients with cardiac arrest. But this is not a routine cardiac arrest, as you know from other studies like TTM or TTM2 or from many registries. We are focusing on patients with refractory cardiac arrest. As I said before, those are those patients who don't get ROSC within the reasonable time. And the average time for patients in the majority of studies and registries is below 25 minutes of CPR. And we are focusing on patients who have a much longer time. They need to be resuscitated. And in those cases who are refractory, their outcome is very poor. And the majority of them, or basically all of them, die if you use routine measures. And therefore, we started to use the ECMO and immediate transport into hospital and putting patients on ECMO and then to investigate them invasively, meaning we did coronary angiographies and eventually PCIs, as a lot of those patients have a acute coronary disease as a cause of their refractory cardiac arrest, because coronary ischemia or myocardial ischemia is a frequent cause of refractoriness in this setting. The study design was actually comparing a bundle of interventions, intra-arrest transport under mechanical CPR, which means that we put a patient on a mechanical device which performs cardiac massage. And we, after transporting to hospital, when the patient has ongoing cardiac arrest on admission to hospital, we put a patient emergently on ECMO, which is called ECPR, extracorporeal cardiopulmonary resuscitation. And immediately after that, we perform invasive investigation, which is mainly coronary angiography. And eventually we treat acute coronary disease, like coronary occlusion, or we perform other invasive investigations like pulmonary angiography or whatever needed at this point. And we compare this bundle of interventions to standard advanced cardiac life support, meaning that the patient has been resuscitated on scene, and if we get a return of spontaneous circulation, the patient is transported to hospital and treated regularly as everybody following a cardiac arrest with regular post-CPR care. Concerning endpoints, we actually have chosen a very hard endpoints for our study, which was 180 days survival with a normal or favorable neurological outcome, which is cerebral performance category 1 and 2. And it's important to point out that majority of studies in cardiac arrest and comparing ECPR in the non-randomized fashion used only 30 days of outcome or hospitalization outcome. And we have also seen in our study that there is a evolution of neurological outcome during the weeks after cardiac arrest. And we had several patients who actually awakened after those 30 days. So it's important to have such a hard point to prove or not prove the benefit. So our primary endpoint was survival with favorable neurologic outcome, 180 days. And our secondary important outcomes was neuro recovery within 30 days, meaning those patients who recovered within 30 days, and cardiac recovery within 30 days, which means that the patients don't have any pharmacological or mechanical support during those 30 days. Our findings are that we actually did not prove statistically significant improvement in primary outcome, despite the fact that we have seen numerically a obvious difference in appearance of primary outcome. It was 32% of favorable survival of those 180 days in the hyperinvasive arm, and it was 22% in the standard arm. So there was almost 10% absolute difference, but it did not reach statistical significance. However, we have seen a statistically highly significant difference in the neurological outcome after 30 days, so our secondary outcome. And we have also seen a statistically significant benefit in two subgroups. First, there was the subgroup of patients who have been resuscitated for more than 45 minutes. And there's been very strong, it was very strong in favor of those patients who had undergone the hyperinvasive approach, meaning those transport and ECPR, versus those who were transported after ROSC to hospital. And to be exactly precise, we had those patients who were resuscitated more than 45 minutes. We had 20 patients who survived in the hyperinvasive arm, such a long CPR, versus only 6 patients in the standard arm who survived such a long CPR. And it's important to point out that in those 6 patients who survived in the standard arm, 4 of them were actually patients who were crossed over from the standard to hyperinvasive arm, which brings me to an issue of crossover. As you know, in such difficult studies, crossover occurs, and we allowed crossover. And in those patients who crossed over from standard to hyperinvasive, and there were only 11 patients, so below 8%, 5 of them, so 5 of 11 patients survived favorably. So it's important that we pick up the right patients to cross over. And this actually brings even more significant difference to our results and brings more strength to support results. We think that based on this trial, and this is important trial, as you know, because there's no other larger trial as we have randomized 256 patients. And during almost 80 years of study, and this is difficult to find the proper patients. And other studies have shown, similar to ours, that between 5–7% of patients with cardiac arrest are suitable for such kind of study. So it took us a long time to enroll enough patients. And it's important to say that those patients may benefit from what we were doing. So they may benefit from the early transport to cardiac center and early ECPR. The extremely important point to discuss is when to start this transport and when to think that a patient might be suitable for it. This is a time issue. It must not be too early, it must not be too late. There's been other studies showing that probably within 15–16 minutes of advanced cardiac life support, if we don't get ROSC, which is together with the phase before the emergency service comes to scene. So it's around 10 minutes plus 15 minutes. So around 25 minutes if the patient doesn't get ROSC, the chance for favorable survival goes very steeply down. So this is the right point to think about the ECPR track. So to keep CPR and bring patient to hospital. So what we think is that based on our trial, we cannot recommend so-called 1A recommendation because our study was not significant in its primary endpoint. However, we have shown that the proper patients and subgroups may benefit. So there is stronger benefit, there is stronger evidence right now for doing this in a very selected subgroup of patients first, and in a selected scenarios and a demographic area, which is well covered by well-functioning pre-hospital care and cardiac center, which is available 24/7 for performing ECPR. The next steps are that definitely we need another multi-center study, randomized, to prove the benefit, to prove the concept that we came out with. And our immediate steps now will be that we'll try to perform meta-analysis from the results of randomized studies which are available at the moment. And then we'll set up a multi-center randomized trial. That our study is the first one that has shown in a randomized fashion that intra-arrest transport with mechanical CPR plus immediate ECPR plus invasive investigation is feasible and may function well, and it's also safe. We have also shown that subgroup of patients may survive much better when we use this approach. And now we have to definitely define the demographic areas and the type of patients that should be enrolled in such a track.